Okay, this chapter is we're gonna be talking about bipolar disorders, and again, as we talk about bipolar disorder, you're gonna see some of the same clinical manifestation or the clinical pictures you've seen we talked about in depression. Again, these clients with bipolar disorder, they could be have chronic, recurrent, or life-threatening. It's a chronic, recurrent, life-threatening illness. Also, the bipolar could range from mania, again, depressive disorder, or it could be mania and depression coincide. You can have some of the same issues. Also, when we look at the bipolar, there are different bipolar 1, 2, cyclothermic, and also rapid cycling depression disorder, which again, a client could be hypermanic. They could have become hypomanic, manic rather, meaning if they're hypermanic, they real fidgety, they walk a lot, they eat a lot. I mean, they do not eat because they moving about a lot. They wander, so they're going to be at a high risk for injury. Those clients that are hypomanic, they have a tendency to be lethargic. They sleep a lot. Again, they don't eat. They become anorexic. And then also you think about looking at mania, hypomania, or hypermania, and then also they may go through phases of depression. So you can see how depression and bipolar kind of overlap. You could have both. And so when you do that, like I said, these clients they can be at a high risk for injury, suicidal ideation, so that they can have a lot of complication as well. And if you look at these specifiers here, they are the same as the one that we talked about with that depression, being they have those catatonic features. They psychotic. Also, they may have um they get anxious, very depressed. Anxiety level increases. So we look at unipolar versus bipolar. As you can see here, with unipolar, that you see it affects women more than men. However, they have problems sleeping. Their appetite is lost. They become depressed when they become agitated. Also, you may also see some physical symptoms like somatic disorders, heart problem, diabetes, obesity. Then again, bipolar, they're less likely to be females. Most time, you see a high risk of these in men for the most part, but they affect both men and women as well. Also, again, they also have a change in appetite. They have some psychomotor retardation clinical manifestation. They're high risk for suicidal, high risk for substance abuse. They become psychotic. They also have some cognitive symptoms. Again, like, as I said earlier, these are some comorbidities or other issues that these clients may be experiencing. Like I said, the heart disease, metabolic, endocrine, type 2 diabetes, and obesity because of their diagnoses. Some of the risk factors, again, could be genetic. It could also be environmental. It could be genetic. Again, like I said, it could be related to the neuroendocrine factors, neurotransmitters, neuroanatomical factors. So it could be a multitude of things, and if just about every aspect, we also have to consider the client's culture, their background, their an environment they live in, their socioeconomic status. So again, like I said, these features kind of overlap when we're talking about depression. They overlap each other. So let's just identify some of the clinical manifestation with bipolar. Uh, One being that they become delirious mania. This is where they have a rapid onset of delirium. Then they have delirium plus they manic, and then they become psychotic. So again, these clients are at high risk for injury, hurting themselves or others. And then we look at mania. Some of the things that you see, like I said, they're hyperactive. They may be mild, maybe wild activity. They become manipulative, profanity. They talk, profane language. They find fault in everything. Again, they like to exploit others, those vulnerable people, like, well, again, taking advantage, try to manipulate people. Again, they don't get enough sleep. They sleep. They do more walking and wandering than they sleep. Again, they lack a lot of sleep. They don't eat. So when they don't eat, they don't sleep. Again, they can have some health problem, physiological problem. They could have physical exhaustion. They can even die due to a lack of eating, and also that energy is up. They're very hyperactive. Metabolic system is very increased. So if we don't get them on medication, the mood stabilizers, they could die as a result. They could hurt themselves. Hypomania, like I said, they flat affect. They may sleep a lot, so they can go from one to the other. They become hypomanic. So again, those are the stages that they go through. Uh, Also, we talk about their speech behavior, their thought processes. They have a flight of ideas. They may be paranoid. They have a sensory perception. They may see things and then that well, you don't see what I don't see those. I don't see those bugs crawling. So you try to try to understand their perception of reality. Circumstantial speech. They may have rapid speech. They like I said, they use a lot of profanity. They talk a lot about sexual explicit, and then have that clang association language. They just speak, and then they like I said, their speech is very mixed. They'll talk about things that nobody understand but them. So you don't try to argue with these clients. Don't try to change their perception. We try to reorientate them to reality. And like I said, these are some nursing diagnosis, not all inclusive. We talked about they're going to have some sleeping problems. So, of course, impaired sleeping. And then again, we look at their cognition, their behavior. Sometimes they become very angry. And then also, a lot of times when these clients are diagnosed, or they go through a stage of remission or go in relapse, a lot of times they go in relapse because they don't take their medicine. They don't adhere to their medicine. And we talked about the reason that they don't adhere to the medicine. They don't like the adverse effects of the medicine, or the way it makes them feel. So when we look at the outcome, and they go through phases. Phase one, they be in acute manic phase. The goal in this phase is to prevent them from hurting themselves and then maintaining their safety. We want to make sure we not only take care of their physiological, the psychological needs, their behavior issues, but we also want to maintain their physiological needs. Uh, those goals should be realistic. Like I said, if a client is not eating, they walking, wandering, we don't want them to get dehydrated, become anorexic. So we have to give them, like I said, food that they can walk and eat with. So phase two is continuation maintenance phase. The goal here is to continue to reduce, provide resolution to their problematic symptom, whatever the symptom are, whether it's physiological, psychological. We want to meet those needs. We want to prevent these clients from going from relapsing, and then also help limit the severity of their and duration of the future episodes. So in the maintenance phase, this is where we're going to again make sure they have the resources for their medicine. Make sure they have their medicine, because most time they don't take the medicine because sometimes they don't take it because they don't have the medication or resources to give their medicine. So they're non-compliant. So we need to determine why they are non-compliant. Just we can't say, well, they're non-compliant, they won't take their medicine. They may not take it because they may not have it. So this is where we plan the care, involve social service, and get all the resources we can. So again, our goal is to uh, target our care specific, you know, to based on the symptoms and any coexisting illness. Say, for instance, if they are diabetic, not only we're dealing with the mania or the bipolar disorder, but we're also having to deal with um, the um, the diabetes. So again, during the acute phase, we need to focus on the physiological stability of these clients while maintaining safety. Remember, I said we want to make sure their physical health is under control. If a client is manic, they agitated, their blood pressure is going to be up, their heart rate is going to be up. So our focus is to get that blood pressure down, get that heart rate down. Then again, we need to continue again in the continuation maintenance phase. Once we get them stabilized, we want to keep them there. And to do that, we have to get them in treatment. Okay. And speaking of treatment, we talked about milieu therapy. This is a safe environment. in this environment, we provide everything that this client needs: social services, psychiatrists, therapy, and it's in a controlled, safe environment. And they may have to go in seclusion. Again, we have to keep them from hurting themselves or others. We've already talked about lithium. Lithium is a mood stabilizer. Not only with these clients being on a mood stabilizer, they may be taking some anticonvulsant drugs as well. Carbamazepine or Tegretol is one of the one that's commonly used. Lamotrigine is also a drug that's being used. Valproic acid also. So not only will they be on the lithium, the mood stabilizer, they may also be on some anticonvulsants as well. Analytics, clonazepam or clonopin, and lorazepam also it's been used in these clients as well to help with their anxiety level and their mood as well. Then we talked about the electroconvulsive therapy. If, um, um, if they're not responding to the medication, then we may have to they may have to resort to the ECT therapy. So clonazepam and lorazepam, like I said, some of the analytics that may be used. So our goal here is it's going to be safety, uh, also while maintaining the client's legal rights as well. We want to provide that care that is safe and effective to that client who's in that acute manic state phase. Again, so safety and physical needs. They need to be in a structured, safe milieu environment. Need to meet their nutritional need. Like I said, their sleep and rest. They need all the sleep that they can get. Hygiene, elimination. Then again, when we talk about legal consideration, when we talked about restraints, these clients may have to be restrained, may be in seclusion or restraint. And the only time that we will take these clients out of restraints, for the most part, if they've done something or attempted to do something to hurt somebody, we need to make sure that they really show remorse, that they understand what they did was not favorable. So again, a lot of times they'll tell you, "Oh, I'm okay now. I just want to get, let me out, let me out." But we have to note that they are showing remorse before we take them out of the restraints. And like I said earlier, you do not need a physician order to take them out of restraint, but you do need to have one to get them in restraint. Now, there are times we may have to restrain the clients and then get the order later, but we need to get that order as soon as possible and get it on in the chart, okay? When we communicate with these clients, it needs to be firm, calm approach, short sentences, concise expectation or statement. Don't yell, don't scream. Give them clear direction. Don't overwhelm them, like tell them to do multiple things. You want to, remain neutral also. Don't argue with them. Okay, be consistent, of course. Then again, we need to have frequent staff meetings rounding on these clients because everybody needs to know the behavior that these clients have been exhibiting, whether they are progressing or they are declining. So that's why we need to have frequent staff meetings with these clients. Uh, and everybody needs to know what the plan of care is, because when we set those limits, everybody needs to be doing the same thing. One nurse can't do one thing and then the other nurse can't give the clients, give them a pass. We need to be consistent with these clients. And then again, like I said, we need to firmly redirect that energy into more appropriate and constructive channels. Again, if they're doing something, just bouncing around, thrashing about, give them something to do to kind of slow them down. Maybe do a word puzzle, something like that, or just sit down and listen to music. We need to redirect that energy. And then we need to use, again, distraction techniques like tools to de-escalate. Try to distract that attention. When they're in that manic mode, we need to try to do something to redirect these clients. Okay. And like I said, the milieu, it needs to be an ideal therapeutic milieu. Like I said, the atmosphere, you don't need to put somebody in a room with somebody with a lot of noise and, distraction. We need to use decreased stimuli. We need to give them, they need their space. They don't need to be in a competitive activity. If you're going to, like a competitive activity in an inpatient setting, would be something like playing cards or dominoes. So once if they start losing, they're going to get upset. They're going to start throwing things. So we don't want to put them in a competitive environment. Observation, these clients would need observation. Whenever it's possible, they need to be in a private room so that the patient can be encouraged to return to the room when they're showing signs of agitation. If they're agitated, you don't want to put them in the room with anybody else. So if all possible, they need to be in a private room. So whenever their patient activity begin to escalate, we need to employ additional intervention. Again, de-escalation, medication, and seclusion. Okay, so that's what we need to do to get these clients under control. So when you hear the 3 to 11 shift report, you learn that one of your patients was aggressive during a manic phase and restrained with wrists and ankles in the seclusion room. Which nursing actions is your top priority? Do you want to offer them fluids, snack, and toiletry? Wake your patient to assess and assess their vital sign. Do you want to check each extremity for circulation? Check the MAR for any medication that it's administered or any medicine that's needed, or which do you need to assess their mental status? Okay. Again, what you want to do, you want to wake your patient and assess their vital sign. Although the other choices are correct, but priority, awaken that patient, we did make sure and checking their vital sign because we want to make sure that they're stable, their vital signs are stable. So again, you see the word assess here. So you always want to assess your client before you, unless it's an emergency. Okay. Of course, we want to offer them fluids and snacks, but we definitely want to assess our client, make sure they're stable. So Mr. Kwan, a 47-year-old single man, is admitted to a crisis stabilization unit of the Community Mental Health Center. The police found him in front of a movie theater, dressed in a robe, wearing a hat with peacock feathers, and walking barefoot. He was shouting, "This is my theater, I own it, and I own the whole movie industry. I have billions, billions, gazillions." His actual one diagnosis, bipolar 1. His most recent episode is manic severe with psychotic features. You're the nurse assigned to this client. What are your best intervention, you think? So again, he's on a medical stabilization unit, and again he's saying that he owns that theater. So of course that shows that he has bizarre thoughts. He has his perception. It's not real, and again he's very psychotic. So again, like we said, we need to make sure he's safe. He does not impose a threat to himself or others. And then again, that he's not going to be doing it, having distracted behaviors and provide. Then again, we got to make sure that we provide any medical stabilization for this client. And also, we want to get him in the maintenance phase, like I said, make sure he's on his medicine. But again, in this scenario, we need to make sure that the client is safe and he's stabilized. Okay. And again, get him in, make sure he's taking his medicine. So as we talked about lithium as being one of the drugs used for bipolar, it is a mood stabilizer. And if the client is taking it, they may tell you, "Well, it's not helping me. I don't feel it. I don't feel it." So what you need to let them know, that it requires anywhere from 3 to 6 weeks to show full therapeutic response. But however, while they're on that medicine, we need to be monitoring their serum lithium level due to the narrow therapeutic toxic range. Now, these are some of the side effects that are expected of this medicine. So again, teaching the client the adverse effects of the medicine is going to be very important. The expected side effects could be fine hand tremors. They could be urinating a lot. They could be thirsty, nausea, weight gain, sedation. They could have acne. They could have some cognitive problem. They could even lose their hair. So these are expected side effects of this medicine. That every time I get into a conversation, the phone start ringing. I thought I had it off, so I apologize. However, like I said, the advanced stage of lithium toxicity, you're going to see coarse hand tremors, persistent GI problems. The clients become mentally confused, muscle hyperirritability, EKG changes. I'm sorry, EEG changes. Also, they have incoordination. What we're going to do again, we're going to hold that medicine, get a blood level, reevaluate the dose, and then again, make sure we treat any symptoms that these clients may be exhibiting. Okay? Okay, severe um, lithium toxicity. These clients could develop ataxia, serious EEG changes, EKG changes, blurred vision, chronic movement. Lord, they're gonna be losing a lot of fluid, urine, gonna be diluted. Tendinitis, blurred vision, seizures, they can go into seizure, a stupor state. Severe, the blood pressure is gonna drop tremendously, losing all that fluid, they can go into a coma. Usually they die secondary to pulmonary complication. There's no known antidote for lithium poisoning. However, we want to stop the drugs. We want to facilitate excretion, meaning we want to get it out the body as quick as possible. And the best way to do that is giving emetic. Sometimes we have to put a gastric lavage tube down and pump the stomach. And then again, we have to treat these clients with urea, mannitol, and aminophylline to hasten the excretion. We're trying to get that lithium out of the body as soon as possible. Okay, that's when we talk about it. Facilitate excretion. Okay. Uh, so, so what is likely to occur when a client is taking lithium carbonate has a low serum level? Will they go into low lithium toxicity, low lithium levels, or increase of mania or decrease mania? So if the client is taking lithium carbonate and has a low level, uh, again, they can have a lithium toxicity. Okay, develop lithium toxicity. Alrighty. So, however, there's some analytic anti-epileptics. I'm sorry, um, that also used as a mood stabilizer in these clients. I kind of told you that already, right? Your anticonvulsant, Tegretol, carbamazepine, valproic acid, lamotrigine. So again, these are your anticonvulsants that are also given in conjunction with the lithium. The first line treatment for management of acute mania, again, olanzapine. Y'all seen that on test before. Quintiapine, apriprazole, risperidone, uh, ziprazone, ziprazidone. I'm sorry. Also, we've seen that those drugs on test. You're going to see olanzapine again, fluoxetine also. We've seen those before. They also help manage bipolar. So again, you make sure you uh, look at those drugs again. What olanzapine does and quintiapine, they're used together and they're usually given to get these clients prevent relapse again. So they also are given in conjunction with lithium or valproic acid. So again, we want to make sure we keep these clients from relapsing. So this Mr. Kwang again, he comes to the emergency department with blurred vision, muscle twitching, slurred speech, severe diarrhea. He shows you the triage nurse a card with the following medication listed: lithium carbonate 300 milligrams 3 times a day, clozapam 0.5 daily, and both for sleep and agitation. So, what are your most appropriate action here? Again, if we look at the medicine, again, this client is on medication that you recognize, like I said, both of them causes them to be drowsy, to become sleepy. So again, we have to reassess that medication. What we'll do, we'll stop that medication, hold the medicine rather, and notify the healthcare provider. Okay? So he gets to be discharged. His discharge orders 8 days on the unit. He will be staying with his family member until he's able to return to work. You recognize that he has entered the continuation phase of treatment. So again, what types of education would you include in your teaching plan? Again, teaching the importance of the medication, talk about the side effects of the medication, talk about that they have to follow up getting their blood levels drawn every 3 to 6 months. They have to get get the levels drawn, make sure the medicine is working, that they have it's met therapeutic within therapeutic range. Then again, like I said, they may have to again, that titrate their medicine down.